Well, I'm really pleased to welcome you to the Center for Global Development and happy to see lots of familiar faces. I'm Amanda Glassman. I'm the Director for Global Health Policy here at the Center. And today we'll talk about a report that we've just released. You'll find copies in the front, but it's also online. It's entitled Better Hospitals, Better Health Systems, and Better Health. And I think that's a tip off to how we're thinking about the issue of hospitals in the context of universal health coverage. I think I don't have to convince the group here that obviously primary health care and public health is of vital importance. But a health system is more than primary care and public health. In fact, a hospital is really the symbol of healthcare in a country. It's sometimes the first place that people will go. It's an important source of impoverishment for those people who are forced to use and can't afford to pay. And it's also a source of employment and growth for economies in which these hospitals are based. And although the data is quite poor, what we do know is that there's some evidence out there that many of the hospitals in low middle income countries are not working as well as we would hope. I think in the Lancet Commission on Surgery, they reported that only 4 countries can report in low and middle income countries can report perioperative mortality. So the number of deaths that happen out of all the procedures that are undertaken. And I think that's just the tip of the iceberg. Really, we just don't know much about the performance of hospitals. And not only that, but populations in these countries are interested in better quality hospital care. A Pew poll suggests that about 76% of people in 6 sub-Saharan African countries would like to see improving hospitals as a top government priority. And yet, the international response to all of this has been a little bit all over the place, I think we can say, in the most generous way, and neglect as well. Even though this is quite central, it's quite important. It's important as a share of budget, too, because your hospital can easily eat your entire health sector if you're not paying attention. The global health community has basically left this issue off of the agenda. You can't even name the share of health aid that goes to hospitals. And yet we have a lot of publicized hospital fails. You know, in Afghanistan, we've built a lot of hospitals. In Pakistan, we've built a lot of hospitals. In lots of conflict areas, there's Liberia and Ebola, we've been building hospitals. And yet we leave those hospitals without the systems in place to function sustainably and as part of a health system that together is generating better health. So that was our motivation for putting together this working group. And it was a group of really notable people. It was led by Maureen Lewis and myself. And we came up with an idea for a global hospital collaborative. And we'll talk a little bit more about that in the panel afterwards. But I'd like to present one of our key working group members, who's the Subsecretary of Health for the government of Mexico, Eduardo González Pierre. He is my favorite policymaker. He's also worked, he's just an incredible voice for evidence and rigor in policy in health systems. Prior to Mexico's Ministry of Health, he was the executive chairman of FunSalud, which was one of the first all-health think tanks that was very influential in policy in Mexico and all of Latin America. He was the CFO at the Mexican Institute of Social Security, so he knows about buying that massive quantity of drugs and devices. He really knows health policy. He's lived it all personally. So without further ado, I'll turn it over to you, Mr. Vice Minister. Thank you.
Thank you, Amanda, and good afternoon to all of you. I want to thank the organizers, Amanda, CGD, Jerry, Maureen, everybody that has been so actively engaged in making this possible. I want to congratulate CDG for launching this report. I think you'll find it as a very amazing, interesting report. I think it fits a gap, fits a vacuum in the policy agenda that is very important to get back on the drawing board and get back to work. And I would like to just use these few minutes to sort of give you the perspective on the Mexican side of what this collaborative What would it mean for a country like Mexico? Mexico being a country which is a middle, higher income country, it is a country that is seeking best practices across the world, that is trying to understand how to better manage its health system. And it's also a country which has a hospital subsector which is a mess. I think it's one of the things you want to do in policy first is to understand whether you have a problem before you do policy work. You need to go into the acceptance phase, and you need to accept there's a need for better performance, and that is, I think, the case in Mexico. I'll show you a few slides on that. So let me give you my impression on the Mexican view, going over those three phases of the report. First of all, making the point that we do have a neglected agenda. Second, trying to understand what are the costs from the Mexican case of having this policy agenda, this hospital policy agenda off the map. And finally, what can be done for the Mexican case, and of course, how we can draw upon the experiences. So let me show you the first slide. I think this is interesting. I don't know if you know what this is. Before there was health systems, there were hospitals. This is the picture of the first hospital in the Americas, 1524. It was founded by Hernan Cortés 491 years ago. It was an acute trauma hospital. It was built to care after the Aztec warriors that were wounded in the war, and it's still working. 491 years later, it still functions. You can look it up in the webpage. It offers services, and we don't know what its performance ranking is. Almost 500 years later. So it's interesting to see how hospitals, like Amanda was saying, they're at the keystone of the health system. They are the most visible entity in the health system. Is what people talk about, is what people want in their communities, is where most doctors get trained, is something that is there, and nevertheless, we neglect and look not enough on what they're doing. And I'll talk a little bit about that. So over the past 500 years since Jesus de Nazareno Hospital was built, in fact, you can see that Hernan Cortés in his will decided he wanted to be buried there. And if you never knew where Hernan Cortés was buried, he's there in the chapel. He decided to be part of the hospital. Ever since, for the past 500 years, we've evolved. We now have almost 4,400 hospitals in the country. About 30% of those hospitals are public hospitals. Nevertheless, they account for about 70% of the beds and about 60% of the activity. So we have a big heterogeneous map of hospitals, larger public hospitals, small private facilities. The private facilities do a lot of surgery work. The public hospitals do a lot of complex work. Most of the beds and the care is done in the public setting. And like Amanda was saying, this takes up a very large part of the budget. We estimate, and these are estimates because numbers are difficult to obtain, that about a fourth or a third of the total spending on health is used up by hospitals. Now that is a large amount of help. Now having so much money going into the system, a third of that, why are hospitals not part of the mainstream of the policy agenda? And here's the elephant in the room, which are the hospitals. We just don't talk about them enough. I did just a couple days ago a search on our national health program. This is the 6-year national program of what the government is going to do around policy making, all policy arenas. You look up the word prevention, it shows up 200 times. You look up the word diabetes, it shows up 100 times. You look up the word hospital or hospitals, it shows up 20 times. So 1/3 of the budget, hospitals, and it does not show enough on the policy documents. So why is this? Why are hospitals not part of the policy or explicit policy agenda? I would propose three things. Number one is that hospitals are very difficult to understand. They're these black boxes. We really don't know what they do. They take up all this budget. There's a lot of important people running them, but we just don't know. We just know that a lot of inputs go into them, but we don't know what comes out of that. We know there's discharges. We know there's stays. We know there's surgical procedures, but how does that relate to the rest of the system? And trying to measure that and trying to understand whether that's good or bad, or it's enough or it's not enough for the money that has been taken, it's very difficult to do. So one thing is hospitals are complex entities, and we don't like to engage in things we don't understand. That's one possibility. The second possibility is that there's a feeling that hospitals don't produce much health. We know that prevention does. We know changing habits produce health. But we know primary care is essential. But there's a feeling that hospitals don't do the great amount of health gains. And I think that's mistaken. That's part of the understanding that we don't know what hospitals do. But there's a feeling that they take up too much money for the returns on health gains. And the third possible reason why we don't engage much with hospitals is that they're very difficult to establish a dialogue, especially when public hospitals, are run by prominent physicians. The dialogue is difficult, the culture is difficult, the language is different. So establishing a working relationship around policy areas with hospitals is a very difficult thing to do. So we decide to put it aside and don't talk to them. There might be other reasons why we don't engage with hospitals. We don't do policy work in hospitals. And that was part of the discussions that the working group did when they met last year here in Washington, D.C. So what are the costs of not dealing with hospitals? This is a very brief overview of just the Ministry of Health hospitals. I'm using that subset because we recently did a benchmarking exercise. I'll tell you a little bit more about that. But the Ministry of Health, which is the subsystem of the Mexican part that runs the non-socially insured population, it's about 50 million, has 700, a little bit over 700 hospitals, very different hospitals, the small hospitals. We have these things called community hospitals, 10, 20 beds. There's about 240 of them, and they're very different. Occupancy levels are very low. They sometimes don't fit into the definition of a hospital as is mentioned in the report because they don't run 24 hours. And a lot of bad performance around them. Then we have the general hospitals. The general hospitals is the mainstream. It's the bulk of the beds. It's the bulk of the care. We have smaller and bigger general hospitals. That's about another 60% of the total capacity. And then we have the specialty hospitals. And that's the big scenario of what goes on. And one of the costs, there's two ways of looking at the cost, the opportunity cost of not working closely with hospitals. One of them is the opportunity cost of health outcomes. All the unnecessary mortality that is taking place just because hospitals are not being dealt with and there's not enough energy put into them so that they can perform at the best standards. The second way that there is a cost is wastage. There's a lot of wastage in hospitals. These are resources which are mostly scarce in every country, and those resources could be used up by other parts of the health system, and they can produce a lot of health. So not being engaged means unnecessary death, unnecessary mortality, and a lot of wastage. And looking at some, let me give you some figures of what's going on with the mortality gaps and the wastage in the Mexican health system. This is a slide of just plain mortality rates across hospitals the bars would be the states, 32 states in Mexico. And you can see the big diversity. These are big states. All the states, the 700 hospitals are in all the states. There's a lot of averaging here. Nevertheless, you see these big gaps in mortalities across states. So what is going on is that performance is very heterogeneous. You have hospitals where there's too much mortality. You have hospitals which perform well. And what you see in this slide is that if you moved the bad performers to the average, there's almost 5,000 excess deaths that you could have saved. And if you move them to the best performer status, there's 25,000 avoidable deaths in 1 year. That's a lot of avoidable mortality that you can do, just bringing all the hospitals into best standards. That is one case. And of course, you can go into this. We have some very interesting graphs around heart attacks, mortality around heart attacks, which is almost 3 times the OECD average. And you can see hospital by hospital how many people are needlessly dying just because they're not reaching a hospital that actually resolves their conditions. If you also look at length of stay, which is a very general statistic on productivity, you still see these huge gaps. You see gaps on performance, which are not explained just by some states having sicker people than other people. I mean, the averaging of the complexity of the hospital is done away. And you can turn those average length of stay into unnecessary stays, and you can see how much extra beds are being used up, how many of those beds cost, how much of those hospitals could be proved more efficient. And it comes down to amazing numbers, hundreds of thousands of avoidable hospitalization days. In this case, bringing the low performers to the average amounts to having almost 250 more beds in the system. So the space for improvement is very, very large. On the efficiency gap, this is a very interesting another type of statistics. These are gallbladder removals across states. And what you see is basically there's no policy. You have states which do almost 95% of gallbladder removals by open surgery. And you have states that do 40% by open surgery, the rest being done by minimally invasive surgeries. And the standard is supposed to be 20. Not one state in Mexico is on the Ministry of Health hospitals, the state-run hospitals, is according to international standards. So you can see that there's a lot of inefficiencies doing on this type of surgery. And of course, if you drill down into the surgeries and lengths of stay, both for open and minimally invasive, you see the same spreads. You see how many states are doing excessive lengths of stay for open surgery gallbladder removal, and you see all the states that are doing excessive lengths of stay of something which would be a very easy surgery, whether there's no need to stay overnight, and yet you see these discrepancies on how hospitals are managed. And again, these are averages within the state. If we were to unfold this into a hospital by hospital performance, the gaps would be even more impressive. So, lots of unnecessary mortality, lots of inefficient usage of resources in the Mexican case. And of course, all this can be specified in numbers of deaths, numbers of beds, numbers of dollars unnecessarily used. So what we did last year, when we engaged in this working group and as part of this idea of trying to understand what is going on with hospitals, is we started with a benchmarking exercise. There was a lot of enthusiasm at first. We put the statistics. It was 9 indicators of performance: efficiency performance, outcomes performance, pertinence performance. We should be launching this next week. Our minister will be launching this document. It's the first hospital performance document we've done. It's interesting because the first thing we did, and I'll show you a slide on that, is lots of enthusiasm at the beginning. And as soon as the hospitals and the institutions start seeing their numbers, they just raise their hands and they want to drop off the exercise. So we were left with the 700 hospitals. We go state by state, we go hospital by hospital, and the gaps are amazing. So this is a first interesting exercise. We're already getting some states and hospital managers which are denying the numbers. They're saying that that's not really the reality, which is good. It says that they're actually looking at it and they're concerned about how they fit and how they're being seen by the rest of the system. We'll launch this, like I said, in a week, and we'll see what the response is. But the first strategy we're doing is raising awareness. So to wrap up, what do we think can be done? What can be done, I think, is 5 things. Number one, as I said, is it's important to put the issue on the table, to raise the awareness. If we don't have the awareness of why hospital policy is important, we're not going to get the funding, we're not going to get the energy, we're not going to get the interest, the public interest or the policy-making interest. So the first thing is you have to make a case, and one way to make a case is do some benchmarking on performance, very basic, and turn that into some easily understood statistics, why people are needlessly dying, why resources are needlessly being used, and that is my first suggestion of what can be done. The second thing is making sure we have some metrics in place, some very simple metrics. If we have a problem, if we can measure it, that is a very strong message to the policy community. Hospitals are, as I said, complex. Many people don't think they can be measurable, but output of hospitals is measurable, and I think a lot can be done. The third message is if you raise the issue and you can measure the problem, you have to convince that the problem is solvable, that there's a fix to the hospital problem. And many people think it's very difficult to go engage, make them change, do some different things. So fixing the problem is something that can be done. My fourth suggestion is that hospitals, and this is very well raised in the report, hospitals are away from the mainstream international agenda. We have to bring hospitals into the setting of the SDG talk, the universal health coverage talk. They're seen as something away from all this dialogue that is going on in the international agencies. Hospitals are part of this agenda. They are a very important way on achieving some of the targets of the new SDG 3. They're a very important part of meeting the universal healthcare agenda. We just need to build those links so that make sure that hospitals are seen as an integral part of this. And finally, we need to make the point that hospitals are a very changing, a very dynamic entities. Technology is fastly changing. All countries have demographic changes and epidemiological changes, which are very fast, very difficult to cope with. So you have to have constant attention on policy change across hospitals. It is just too expensive to let hospitals sit and don't react for many years to what is going on in the environment. So just a final reminder, this is a typical curve. It's the change curve, how you go from having all the enthusiasm and getting people engaged. And of course, once you get into the specifics, you look at the numbers, you look at the limitations, you start losing support. But this is a strong reminder that we need the leadership to go across the curve. Once we start seeing real change, once hospitals start seeing what means to be better managed, to better fit in the overall environment of primary care, promotion, prevention, all the public goods around hospitals, then I think you will start getting the support. And of course, if you got the leadership and you got the critical mass, enough hospitals, enough local leaders, enough countries engaged, I think there is a good opportunity of getting back the hospitals on the policy agenda, and I'm sure that's what's going to be done with this report. Thank you very much.
Can I invite our panelists up? Okay, so now we're going to turn to a panel of a few other working group members. To my immediate right is Jerry LaForgia, who's a lead health specialist at the World Bank. He's really the person who had the idea to get this done. He's been working on this area for many, many years. He's currently working in the East Asia region at the World Bank with responsibility for China, but has worked all over the world. Actually, Jerry gave me one of my first jobs, so full disclosure. I'm a fan. Following Jerry's comments, we'll ask him a little bit about how the World Bank sees the opportunities for a global hospital collaborative, how he sees the report, and what might be the way forward. Next to him is Dr. Aryan Hatefi, who's an assistant professor at the UCSF School of Medicine. He is an actual hospital-based physician. He's currently working on a primary healthcare project because that's where all the money is, right? But he's deeply immersed in hospital care, training physicians to work in hospitals effectively. Eduardo, we've already met, and Maureen Lewis, who's our partner in crime here. She's a visiting fellow at the Center for Global Development. She's a professor at Georgetown University. She's formerly of the World Bank. She's another health economist, also with an enormous amount of experience. So with that, I'll turn it over to you, Jerry, for a few nuggets of wisdom. How do you see the future?
Okay, first of all, some full disclosure. I'm in the winter of my stay at the World Bank, and we'll be leaving the World Bank in early next year. Actually, I'll be stepping out of the World Bank and working on this collaborative that Maureen's going to talk about. So just to let you know, so anything I say may be colored by that, but not really, because as Amanda said, I've been working on the issue of hospitals for quite some time in the World Bank, and have led the hospital thematic group. Just some data maybe will set the stage a little bit. We've had in the last 5 years about 38 projects with $5.9 billion of lending related somehow to hospitals. However, that's a little bit like rounding up a lot because in terms of the number of projects that have actually have anything to do with are focused on hospitals, it's 6 with about $650,000 in total. And we did a study. Actually, I think Peter Berman did the study a couple of years ago, looking over all our AAA, all our analytical work, and only of 660 pieces, only 14 were on hospitals. So it's pretty low there. And I did about 2 years ago, I did a survey of our staff on just getting the interest of hospitals, and it was very, very high. It came out, in the 70%, 80%, the need for TA, the need for knowledge, need for training, the need for work on hospitals. Well, then the question is, Eduardo brought this up, kind of why is the gap? What's going on here? And I think there's, besides what Eduardo said and the difficulty of working with hospitals, I also think that there's in the bank, it's a difficult subject. It's not something that you see many people working on. And in terms of the trust funds and the money that we have, the more flexible money that we have to support this type of work in hospitals, well, it's a little bit of money compared to the money that's available for infectious diseases, primary care, et cetera, because a lot of this trust fund money, donor money, is driven by it's earmarked to a certain extent, and we can't use this money, let's just say, for hospitals. Now, that said, what I'm seeing, though, in the last few years is a change away from the traditional hospital project, which is infrastructure, training, IT, and other equipment, to a more service delivery approach. This is happening a little bit more in the ECA region, our Eastern European region, but I also see it happening elsewhere. in which we're taking, for lack of a better term, a service delivery approach to this, in which hospitals are part of reforming a service delivery system, which would include primary care. It would include human resources reform, and the idea is to link hospitals with other levels of care. And the theory behind this is that you're not going to be able to address primary care unless you address the hospital or vice versa, especially at the secondary level, which is much more related to the primary care. So these projects are let's call a new generation of projects at the bank. There aren't that many of them. Sometimes they come with crazy names like the System Rationalization Project or things like that. You can't really read them by the names. Like you can't even understand to actually do a deep dive into components and you see what they're trying to do. With that also, there's a call for more quality improvement in the hospital. Something what Eduardo was talking about, like looking inside the hospital, what can be done. So there's an attempt to look inside the hospital, sweep inside the hospital, clean it up a little bit, make it a little bit better efficiency and quality, but also what can be shifted out of the hospital? What type of transition care or post-discharge care? And so there's a new look at that. The problem is, and this is how I'll end, is that I think at the bank, and one of the good things about leaving the bank, I can say anything else with anything I want with no repercussions.
This is on the record.
Yeah, it could be. Well, they can only get rid of me a few days earlier, so it's.
You'd be thankful, right?
Okay. So is that I guess the short term, we don't have the horses. The problem is that we have built up, I think, in the bank, a technical knowledge base for primary care, for public health, for infectious diseases. I think we're starting to build it up for non-communicable diseases. I think in terms of systems and working with hospitals, we just haven't developed that. And having a type of collaborative would be hugely important for we call the TTLs, our task team leaders and our health specialists to be able to plug into something like this. And I don't know if any of my colleagues from the American Bank or Asian Development Bank who I've dealt with over the years, I'm sure they would say the same thing. I know that the American Development Bank is very active in hospitals in Latin America, and the Asian Development Bank is starting to move into hospitals in Asia. So I think that if this was 10 years ago, I would be in the audience saying, yes, sign me up. Okay, thanks.
10 years later.
Yeah.
Aaron, tell us a little bit. You're sitting in an academic medical center, but you're also doing a lot of work in low-income countries. Tell us a little bit about how you see the need for a collaborative and what directions it might go in the future.
So thank you. It's a pleasure to be here. A lot of what Jerry has just mentioned, I would echo. I think I'll just start by sharing some reflections first that we're sitting here talking about hospitals, but in fact, this isn't really about hospitals. This is about healthcare systems. This is about creating a balanced approach to healthcare systems. And, there are sort of three fundamental platforms. There's the community level, which sort of goes to the individual at home, essentially. There's the outpatient platform, which is effectively what we mean by primary healthcare. And then there's the hospital. And I think everybody who's been involved in this work is not going to present themselves as a zealot for hospitals, because I think that's exactly what we don't need. I think rather the pitch is really that we need hospitals too. It's all three models, all three platforms are really fundamental in balancing the healthcare system, because as Jerry mentioned, the hospital serves as an outlet to these other two platforms, and that improves efficiency of the system altogether. But those other two platforms also serve as outlets to the hospital. And we see, I see that in my job every day. And I see that both when it works well and when it doesn't work well. I mean, I have tons of patients that I take care of in San Francisco that I can't discharge because I don't have a safe discharge plan for them. And then vice versa. So I think what we really need is integration of platforms of care and really a balanced approach to healthcare strengthening. That's the first. The second point that Jerry brought up, which I think is a lot of what the academic centers will start to add to a collaborative, is this idea of quality. So we know that access to hospitals is poor. That's both financial access and geographic access. But Ashish Jha at Harvard wrote a nice editorial in the New England Journal some time ago about the need for quality in global health. And he has a line that I just want to sort of bring up now, is that more is not better, better is better. Mm-hmm. And that really spoke to me, because I think that's a lot of what I do as a hospitalist, is that we try to improve the value of the care that we provide. And I think we don't see enough of that in hospitals worldwide. And that's both cost and quality. So it's not one or the other. And I think that's the political danger of talking about value, is that oftentimes it gets equated to one or the other and not both at the same time. So, in terms of what the academia can provide, I mean, I think a lot of what we're doing sort of at UCSF is, and elsewhere, is exemplary of that and needs to be ramped up. So things like training programs. UCSF has a program called the HEAL Initiative, and I would encourage any of you to look it up. And that's sort of a shameless plug as well. But the HEAL Initiative essentially aims to put physicians training in hospital medicine in low and middle income settings to develop capacity. And I think the ephemeral relationships that we have with institutions just frankly needs to stop. I think we need lasting partnerships, and that's sort of point number 2, is that I think we need to start twinning and start pairing and start really having a bilateral exchange of information. I think that's such a robust way to produce meaningful research for health systems globally. So not just low-income countries, but globally, rich countries as well, because there's so much to learn from that bilateral exchange. And then I think the advocacy side, I mean, I think that research can really start changing the way that we think about a hospital, for instance. Just the idea of a hospital being cost-effective is not really well established, and I think that's probably understatement, major understatement. I mean, but I think it can be considered cost-effective, and I think the Global Surgery Report, as an example, showed that, and that's just tip of the iceberg. So things like like Eduardo mentioned, how to incorporate it into the SDG agenda. I mean, I think that's a valuable role that academia can play. And then there's a powerful organization called the Consortium for Universities for Global Health, which I think in many ways represents the best of what we are able to know and can play that advocacy role. So maybe I'll stop there.
Yeah, great comments. Maureen, do you want to say a little bit about what you see as the priorities for work under collaborative next year?
Yes.
So yeah, we have a lot of really big ideas, as you may have noticed in the working group. So
a lot of big things. So thank you, Amanda, and I want to thank Amanda for driving this and making this happen. It's interesting, when we had the meeting, the communications director came in and stayed for about about a half an hour, and has caught me a couple of times in the interim saying, "So what happened there?" He said, "There was so much energy in the room. There was so much excitement in the room." And I think it sort of plays to this idea that there hasn't really been a great deal of work in this area, but there are people who've been frustrated by not being able to do it, not being able to talk about it, and not having sort of the resources to pick up on the kinds of things that Eduardo talked about how do you make these hospitals work better? How do you get to something that's a cost-effective hospital, which, Ariane, I wonder if that's an oxymoron. It's really hard in the US. We don't even know what our costs are in the US. And I think that's indicative. But I also think that there's a lot going on in the US and in Europe that also sort of can inform what we do going forward. So one of the things that I have done, and I'm doing with Jerry, as he mentioned, I've launched a startup called Acesso Global, and it's where hospitals meet the healthcare system. And what we want to do is pick up on this agenda and work with CGD and others like UCSF and the government of Mexico to try to move this forward in 2 areas. One, in terms of data and research and information, and that being shared across the world, basically, and you can do that now with websites, and also provide advisory strategic services where we can help on some of the kinds of things that Eduardo touched on. So our intent is to get this going. We'd like to see it move to be a collaborative, but as in so many things, collaboratives mean that you have to have a lot of money because you're trying to integrate a lot of places. But I do think that when you work in hospitals as I think all of the panels have mentioned, you really have to touch on a lot of different kinds of areas. There are things having to do with the internal of the hospital. There's how it fits in with the policy agenda. It's how do you track outcomes and performance, and all of those things really require different kinds of skills. So I think this black box that Eduardo mentioned is also sort of driving sort of an interest in what is it that black box is producing, because people want what's in the black box, but someone has to pay for it, and that's one of the quality issue just is sort of on top of that. So I think those are sort of the integrated sort of issues that are on the agenda that we would like to take on and work with others to try to address. Now, we have made some progress, and we've started working with a number of people, including the government of Mexico, but also some NGOs, with the Global Fund, with the regulator in Brazil. And these institutions and individuals are really interested in very different kinds of things. They're interested in internal management. They're interested in payment systems and how that drives incentives. They're interested in quality. They're interested in how do we get there. And I think that one of the big things that, again, Eduardo touched on, I think is really fundamental, is hospitals are changing worldwide. And if you look at Europe and the US, the whole set of incentives have changed. And they're driving something to raise quality and contain costs. And that agenda applies to the low and middle income countries. It's just that they haven't had the attention that they deserve, that I think that this working group highlighted and that Amanda outlined. So thank you, Amanda. And hope we all can work together going forward.
Yeah, and I think, the idea of a collaborative really is that, it's not just economists, and it's not just the physicians that are working, and it's not just universities. It's actually that these hospitals require a set of skills that is not sourced in a single place. And it's not like a task team leader at the World Bank is going to be an expert on all things hospital. No, he or she has to search on the outside, and I think that's really the idea of the collaborative. Let me end up our panel section by asking you, Eduardo. I liked the many stages of acceptance of death now that starts with denial. So I think we're sort of passing through the denial period. But how do you think internationally we might position the kind of collaborative that we've talked about? You mentioned the SDGs, but in terms of alliances to make, governments one might partner with, how would you see that moving forward?
Well, like I said, you need to raise the issue, but my feeling is, it was mentioned, different countries that have different needs or different concerns. One thing I really like about the recommendations, the framework in which it's set, is that it does 3 splits. It talks first on the hospital agenda at the micro level, the black box, the within internal organization, which is something many countries are concerned about. It's the plain efficiencies and mortality gaps. Hospitals don't run very well, and you need basic managerial capacities there. So I think, but it also raises the issue of the environment. The policy, what Ariane was saying, that you can't see hospitals just as isolated entities. They need to interact with primary care, with community care, etc. So some countries would be concerned about just having basic functionality of a hospital. Some others are more organized. And some things you see in countries is you have both agendas. You have the South and some basic needs. You have the North with other basic needs. You want to worry about diabetes. You want to worry about acute care. So the document does that. It says there's an agenda on the internal, and there's an agenda on the external environmental policy. The other thing that I think is very useful is the mix between the economic sense, public and private goods. So you do need to put together some public goods. I think the most important thing, or most appealing thing, at least for the Mexican case, is there's a huge need for an exchange of best practices, ideas, what's going on elsewhere. It's very difficult to go out and try to understand who's doing what, and where can you get in touch with them and get more data on what's going on. So just providing this public good, which is the exchange of best practices, is very necessary. But at the same time, you don't want to leave things just as a public good, you do need the follow-up, the assistance, the hands-on policy. So the document also does that. It's the boxes that I find very useful. And of course, you need to prioritize and you need to do the time frame. So there's things you can readily do, and there's things you can, it's going to take time for them to mature and eventually get them going, but you need some quick successes, some quick results, something you can show very fast, what this collaborative is all about, what is it delivering, where's the value added, and as you get people engaged in that, then you throw in more of the medium-term to long-term instruments and policy. So I think just putting that framework in practice and showing it to countries and telling them what they have to gain on this, I think it's going to be a very good. And count Mexico in.
Yeah. Well, I mean, you're such an example. You know, if you look at that report that benchmarks public hospitals in Mexico, that is incredibly unique. I mean, imagine if you could do something like that for both public and private sectors. If you could do this in India, if you could do this in other countries that have a lot of their spending in this area, and we really just don't know how they perform. So great. Thanks for those suggestions. Let's turn to the audience now. We have about 10 minutes. Please say who you are and where you're from, since Bill McGreevy is in front of me. I call on you.
I teach over at Georgetown, where Amanda is coming. Lecture dinner, of course, is there. We're very lucky to have her with us. Maureen teaches it there. Talking about Mexico makes me think of a neighboring area called Texas, where Atul Gawande wrote a very interesting article about huge differences in the operations of the medical services between two towns there. So it may look difficult in Mexico, but you've got neighbors who have problems too. The question I want to ask is about something that I think of beginning with Julio Frank. And a friend of mine in the bank says for her, one of the most important things that he offered, he and his colleagues, was the integration of vertical and horizontal systems into something diagonal. And it sounds in a way that that idea is some of what you're maybe thinking about here too. Does it fit together?
Okay, hold on that. Let's take 2 more comments. Alex in the front row. And I should say Alex Praker was also a member of our group.
Yeah, as many of you know, I've left the World Bank 3 years ago, and since then I've been both in the private sector and also at a hospital in New York, Mount Sinai. And I've been very impressed how the Affordable Health Care Act has had such a dramatic impact actually on the health, on the hospital sector, which I don't think was anticipated initially. So I'm just wondering, in Mexico, one of the examples that I'm taking from the Mount Sinai area is that something as simple as hospital-acquired infection, which has been a major, major problem. Under the new incentive environment, where hospitals are being seriously penalized for readmissions because of infections, it's actually having an effect. So you're now having the senior administration in the hospital in Mount Sinai is really putting a lot of energy into not having patients come back because of hospital-acquired infections. So I'm just wondering, I mean, this is sort of, in terms of levels of incentive, that's a high-powered incentive, it's an economic incentive. How can you, as a public policy person, bring those kind of incentives maybe into the Mexico system in a way where you really get the actors to change their behavior? It's not just preaching to them that it's not just a regulation. It's something that actually, at the bottom line, either hurts them or benefits them a lot.
Yeah. Okay, third, right there.
My name is Shilpa. I'm representing Oxfam International, and recently I read a blog by Maureen where you highlighted the need for governments in a lot of countries to seek support from the World Bank and from IFC for funding their new hospitals. But there's cases like Lesotho, countries where half their national budget have gone towards private partnerships with IFC to fund health projects. And I was wondering what your thoughts are on these private financed projects.
Excellent. Great. I'm glad you brought that up. Thanks. So let's start. Do you, the diagonal idea, of course I have to ask. Eduardo, should we start with Arian? Do you want to say something about the ACA and its impact on hospitals? We had someone from the Center for Medicaid and Medicare Services come and talk to us actually about it's really a pay for performance.
Yeah.
What do you think? Good, bad, ugly?
I think it's good. And of course, I definitely want Eduardo to comment because the question was also about specifically Mexico. But I think the idea of accountability. So Maureen brought up a great point about how we need to really sort of hold health systems to the same standard. And the framework that I really like to apply is the triple aim. So cost, patient experience, and population health. And I think the Affordable Care Act does a nice job in creating accountability organizations that pay attention to those three things. And particularly on the hospital side, hospital-acquired infections were mentioned. We know that that's a huge problem, or it historically has been a huge problem. And the incentive structure is now such that we can't afford to have more days in the hospital because of preventable problems. And so I think that's been a huge catalyst. And it's also a patient experience measure as well. I mean, people don't want to stay in the hospital. They don't want to get these hospital-acquired infections. And it's not just infections, it's things like blood clots and so on. I mean, there's a lot of preventable problems that are in the hospital that I think accountability is really good for. The other thing that I'll add in terms of the Affordable Care Act, it also makes hospitals pay attention to who are the high utilizers, who are the patients that are sort of in and out of the hospital and are the most fragile. And it forces some linkage between outpatient and inpatient systems that allow for taking care of these particularly sensitive patients. And there's quite a lot of them, as we know, in a high-income country like the United States. A large chunk of healthcare spending is spent on a very, very small percentage of patients, and oftentimes at the end of life. And so, thinking about, well, how do we deal with that? Well, a lot of that happens on the outpatient side, and it's forcing the hospitals to talk with the outpatient doctors, and the outpatient doctors to talk to the hospitals, and also get creative. I mean, community health workers, for instance, is not a model that's really sort of common in rich countries, particularly the United States, and that's something I think, something like what we're starting to see a little bit more of is more community outreach. So maybe I'll leave it at that.
Yeah, Eduardo?
Yeah, on the diagonal, I think it's a great question because for Mexico, and I think many other middle-income countries, developing countries, target 4 SDG 3, which says 30% reduction of premature mortality on chronic diseases, on non-transmittable diseases by 2030. Now, the only way you can achieve that is with diagonal thinking, because you have to go and look, let's talk about cardiovascular heart attacks, and that is the vertical. But the only way you're going to reduce that mortality is you look at all the spaces that Arian was saying. You have to strengthen the hospitals. You also have to do the primary care. You also have the community care. You have to do the regulation and the protection. So you have to do all the strengthening across one disease group, which shares the same risk factors and shares the same type of hospital care. And you have to strengthen the human resources around that. So my feeling is that the diagonal approach is the way to make the universal health coverage agenda and the SDG 3 agenda fit, disease by disease. I think that's a great point.
Okay, Maureen, and then maybe Jerry, do you want to say something about private finance and public hospitals? And
Yeah, okay, thank you. And I want to touch on this pay for performance because I've been to Brazil twice now. They're really interested in this, and they sort of see this as a way to deal with some of their chronic disease problems. And the triple aim is very much a part of what they're talking about, and they don't know how to harness it. They don't know how to do it, but they're really quite intrigued. But one of the real problems there, as in most other countries, the hospitals don't know their infection rates. So it's very hard to hold them accountable for something that is not being measured. So it goes back to this idea that there are a whole series of sort of things that have to be put into place to make things work. And it's very hard because it's a black box and because it's a complex system. But I think that what this does is it puts on the agenda some things that are very measurable, which I think you also mentioned, that you can track the system on. It's just that you get resistance. And I think that that's very important. But I see some increasing interest in this, in how to deal with it. And I think the Affordable Care Act has been hugely successful in a short period of time. Whether it's sustained is something else, but it's really achieved a lot of its objectives. So to get to the Lesotho, which is one of my favorite issues, because I think the Lesotho hospital actually was a big success. And I think it's a success, one, because quality was raised. Two, you have people who show up for work, which is really important in healthcare. And they do have data that show that in the old hospital, people didn't want to work there, and when they did work there, they didn't show up very often. So, and they know that the quality is much higher in the new hospital. And how much you spend on hospital care is really hard to know. I mean, this is the only reference hospital in the whole country, and it does secondary and tertiary care, right? It's not just a tertiary care hospital. 50% is actually low by some country standards. Brazil, China, Nigeria all spend 70%. And they waste a lot of it, I grant you. But I think that how much is spent is really less important than how well they're doing. And this goes back to this pay for performance, this having data, comparing quality. Because if you have a hospital that is killing 30% of its patients, I'm not sure that I would want a hospital like that, even if I didn't spend very much money on it. And if you could tell me that I could spend twice that, and I would have 2 deaths a year, which would be less than 1%, I would go for that. So it's really a trade-off of preferences and how you position it. But I think that this issue of quality, and Arian raised it, I think it's really very critical. And I think that we do have to look at Lesotho with a little bit of that lens, as well as how much it's costing to run. So, I mean, it's a trade-off question. So I'm also glad you raised it.
And I think it's important that you're pointing out that it's not the amount that we spend on primary care hospitals. It's what the results are against this triple aim.
Very good.
And that is something we need to know more about. And I think maybe in the Lesotho case, the unfortunate part is that we don't know what the primary health care part was producing. We don't know how they were using resources. We know a little bit more about the hospitals because they were sort of forced to do it. The idea is how the system works together to get better care to people. So I think that would be my view. But do you want to say something? You're not IFC, but you've been friends with many people from the IFC.
Well, I won't talk about my IFC colleagues, but I will talk about some studies that we did on PPPs in Brazil and also in India. And I've seen them on both sides of disastrous PPPs and really good quality PPPs that brought good services, high quality services at affordable costs to poor people, which is certainly the Sao Paulo case. It is a question of getting, I would think, the incentive and accountability environment right. And it's not something that happens overnight, but it is something that can happen. In southern India, a private hospital chain took the government to the cleaners, but the government never had its ducks in a row on what was the contract, what was expected, what were the products, what were the incentives. In the meantime, in Sao Paulo, it didn't happen Tuesday morning, but over 2 or 3 years, they got a good contract management unit in, good contracting, cost accounting systems, and they demanded good quality and good efficiency from their hospitals, and they had both a carrot and a stick approach. And just to give you an idea of just bringing the quality angle, they created a fund, a retention fund that they held back 10% against quality indicators, and it worked. And there's been now, I think, 3 evaluations of that model, and they all saying the same thing. So I really think it's PPP, but within what environment, and especially that accountability incentive environment.
Well, I think, okay, we're going to wrap up now. I encourage you to talk to anyone who was part of the panel, although some of us will be rushing off to the next event. But I really want to thank all of the collaborators that have come together to make the working group report a reality, and now the idea is to make the collaborative a reality. So thanks so much for coming to you.
Thank you very much.